in connection with the University of New Mexico. And again, these sessions are held every Wednesday with a different team every Wednesday. This session is the lower GI endoscopy session. Prof. Thompson, who usually chairs with me, extends his apologies. He's in transit from a conference, so cannot be here to chair. The chat is open for questions, so please feel free to post questions within the chat. And we decided to take a little bit of a different take on things. And I just want to put a plea out there to the audience to please be, we welcome discussion and we welcome input from sub-Saharan Africa. And traditionally, we've mostly had academic centers and usually the training centers within South Africa presenting topics in the lower GI session. But we feel that it's quite prudent that we extend this invite to sub-Saharan Africa. And we really do want input from all over sub-Saharan Africa. So we would like to know what the state of colonoscopy is like in your country, what sort of disease profiles you're seeing, what your practice entails. And in doing so, it just highlights needs for training elsewhere in sub-Saharan Africa. It gives us insight into what's happening elsewhere in the continent, because often we may be, limited to our knowledge is just limited to what's happening in our own countries. And it's good to develop that perspective. And I think that's also one of the ways that we can start creating networks for research and for future collaborations. And I think that's very, very important. So this is a plea to everyone in the audience. If you have any interesting data, any interesting research that you want to share, or if you just like to share the state of endoscopy in your country, especially lower endoscopy, because that's the session that we run here, or myself and Prof. Thompson run. So please feel free to reach out to me and to share that. We'd like to know what's going on in your area of the continent, and we'd like to know what's going on, what your needs are in terms of training. So anything, if you want to share research, you want to share the state of colonoscopy, you want to share your practice details and the type of diseases that you're seeing and the profile of patients you're seeing, it also helps us focus and create content or create topics which are relevant to your practice, not just showing advanced endoscopy and interventional techniques, which you may never see in your practice, and it's not really relevant. So in keeping with that, I'd like to welcome Tendai to the platform. Tendai is an excellent gastroenterologist who's practicing in Zimbabwe. He was trained in UCT in South Africa, and he's been in private practice now in Zimbabwe for a number of years, and he has very graciously agreed to share some of his experience with colonoscopy in his practice on this platform. So, Tendai, we're quite grateful for you presenting here and keen to hear your insights on the state of your practice and state of colonoscopy in Zimbabwe.
Okay. Thank you, Vikash, for that little kind introduction. And thank you for the invitation to give this talk. I hope you can hear me clearly.
We can hear you.
Okay, thanks. So thanks again. And I just wanted to extend my acknowledgement and appreciation, particularly to you, Vikash, for the work you've done so far. I'm actually reminded of the time I first met you, and it was in 2018 at the Spear conference. You were only just starting your fellowship then, and I was only a fellow in waiting. But it's nice to see how far you've come and how you are championing advanced endoscopy in the sub-region. So just a little fun fact for us. So today feels like a Monday here in Zimbabwe because we had a public holiday on Monday and on Tuesday. So our working week only started today. So I'm going to share my screen. Right, so I hope you can all see my screen.
It's all good.
Great, thanks. So I will be talking about, or rather giving a talk on a private clinic colonoscopy series. And this is a clinic that I work at in Zimbabwe, in Harare. And as Vikash has indicated, I did my training in Cape Town in South Africa. So I'm going to talk a little bit about, the cases that we have seen and the experiences of our clinic. So this is a private clinic unit. It's an open access endoscopy facility where upper and lower GI scopes are done, as well as some basic therapeutic endoscopy, which includes small polypectomy, stents as required, and maybe treatment of esophageal varices and such like. So the facility gets referrals mostly from the private sector, so private doctors and private clinics, and then a small percentage of patients actually comes from the public sector. And we deal mostly with adult GI patients. So what I'm going to do is present a series, or rather the findings from 495 lower GI procedures that we performed at this private clinic. As I indicated earlier, the referrals are mostly private, from private facilities, so that's 90%, and only 10% were referred from the public sector. And there was an almost equal number of males and females, maybe just slightly more males, but essentially an equal number of males and females. The median age of patients that were referred for colonoscopy was 52 years, and about 50% of the patients were between the ages of 40% and 67, 40 years and 67 years, with the youngest patient being 11 years old and the oldest 94 years. The majority of patients were Black African, so that was 93%, and only 4.4% were white or Caucasian, and then the rest were about 2%. And of all those lower GI procedures, 97% were colonoscopies and 3% were requests for sigmoidoscopy. So I'll say a little bit about the indications for referral. And we know the symptoms usually that patients present with when they are referred for lower GI endoscopy. And some of the symptoms are pretty straightforward. So you've got abdominal pain, and in this case, this is usually chronic abdominal pain. Once in a while, you get patients referred for subacute or even acute abdominal pain, as well as chronic constipation and chronic diarrhea. There's a category for what's called change in bowel habit here, and this is where patients are reporting some vague changes in their bowel habit, which you can't quite classify as chronic constipation or chronic diarrhea. And then rectal bleeding is often pretty straightforward, and for most of the time, this is often mild bleeding that is usually reported at the time of stool, and less often is the sort of bleeding that lands a patient in the ER for emergency care. Some patients report weight loss, and then I also put their perianal symptoms. And perianal symptoms refers to patients that complain of, often it's perianal pain, either at or away from the time of bowel motions. And the other thing that's often reported is, perianal protrusions, which is often seen at the time of bowel motions as well. Some patients referred for abnormal imaging, and then as well screening procedures for polyps. And a certain number of patients also referred for anemia, which varies from, a lot of the patients are just reported to have microcytic anemia. A few of them have iron deficiency, and some of them just have unclassified anemia. So this is the indications for referral and the various numbers in this series. And what often happens is that patients will have a combination of symptoms all at the same time. So it's not uncommon to have 2 or 3 or even 4 symptoms that are reported as part of the presenting problems at the time of endoscopy. But you realize that a lot of the patients, or most of the patients, will have abdominal pain as well as rectal bleeding. And these are the commonest symptoms that are reported. And then you had about 35 patients out of the total number of procedures who were referred for polyp screening. And yeah, so like I said, I think most of the patients will have combinations of symptoms, although abdominal pain and rectal bleeding seem to predominate as the commonest symptoms. And then a bit about the bowel preparation for these patients. So the majority of them had bowel preparation, which was classified as good. So the definition of good is, well, it's good preparation. The endoscopist would have no complaints about the state of preparation and the findings during the procedure. And then you've got patients that were classified as satisfactory. And these are patients where I think at the end of the day, the endoscopist was satisfied with the procedure, although the preparation may not have been excellent or great. And quite often it's an issue of being unable to see some small detail. So for example, missing out on polyps or small polyps. And although these may not be the reason for the primary reason for the endoscopy, what often happens at the facility is that whenever patients come in for a diagnostic scope, there's an attempt to do a screening for polyps at the same time. But however, for the purposes of the diagnosis, satisfactory colonoscopy was considered adequate. So all patients who had either a good bowel preparation or a satisfactory preparation were considered as having adequate preparation. And that was 96%. And then there were the unsatisfactory ones in whom the endoscopist would actually request the procedure to be repeated. Cecal intubation. So out of 480 colonoscopies, cecal intubation was achieved in 446, which was a 93% intubation rate. Some of the reasons for failed intubation would be the finding of an obstructing lesion or technical difficulty with the procedure, sometimes in combination with unsatisfactory preparation. So I'll talk about the findings from these 495 lower GI procedures. And the findings that are highlighted in that graph there usually indicate the common types of abnormalities that are reported at colonoscopy, or the most frequent things. So we've got tumors, hemorrhoids, fissures, diverticular, and polyps. Polyps in this series were by and large incidental findings. There were no cases where polyps were the source of symptoms, so they were all incidental findings. And then hemorrhoids are found quite commonly in individuals who are presenting with rectal bleeding. So we had 29 tumors that were found out of 495 procedures, which was a rate of about 5.8%. And then polyps were discovered in 110 patients out of 495 procedures, which was a polyp detection rate of 22%. Moving on to the more findings, or probably sort of the less common things to find at colonoscopy. You've got a range of abnormalities there, angiectasias, IBD, radiation, proctitis, and so forth. And so in this series, there were 13 patients who received a diagnosis of IBD, at the time of colonoscopy, and this was exclusively ulcerative colitis. And then there were some patients who were diagnosed with angioectasia. Radiation proctitis is something that is also seen not uncommonly. And one of the things that is often the case with radiation proctitis is that in patients who have got a history of radiation treatment, often for cervical cancer, the presence of that history is often is nearly 100% predictive of the diagnosis of radiation proctitis in a patient that's presenting with the relevant symptoms. And then a lot of the patients with the perianal symptoms or even bleeding, the rectal mucosal prolapse was diagnosed not uncommonly. There were a couple of patients who were diagnosed with schistosomiasis, and this was often after biopsy and histology. And then the other diagnoses that we're seeing is ischemic colitis and amoebic colitis, as well as pseudomembranous colitis related to C. diff. And then there are patients with non-specific ulcers and inflammation. And in this category included patients with likely infective colitis or other things such as NSAID-related enteropathy. So these are some examples of patients with radiation-related injury. And these are all pictures from different patients. And in this first patient, this is a patient who had inflammation and this black exudate and eschar due to severe inflammation. In this picture, there's this patient presented with rectal bleeding, and they actually had an ulcer together with some of the characteristic abnormal blood vessels that are associated with radiation-induced injury. This patient presented with changes in bowel habits, and one could see in the rectal mucosa that it was abnormal, vascular effacement as well as tiny ectatic vessels, and they actually had a contracted rectum. Then there was this patient who had quite severe inflammation related to radiation injury. They were treated with some 5-aminosalicylate suppositories, and the inflammation resolved, but they remained with a stricture, which subsequently required dilatation for symptomatic relief. These are some pictures of patients who were diagnosed with C. diff-related pseudomembranous colitis. And these are all pictures from different patients. So the ones that are shown at the top there show quite impressive pseudomembranes. And often when you see this, it's in the right context, it's diagnostic of the infection. And then you had some less obvious cases. So, for example, in this patient, you had very few sort of yellowish plaques or membranes that were quite scanty, as well as this patient who didn't really have the classical appearance, but they just had non-specific erythema of the mucosa, and biopsy was necessary to eventually establish the diagnosis. And I just want to highlight that for these last two patients, they had been on treatment by the time of the endoscopy, so that probably modified the endoscopic appearance. So this is something that is quite interesting because occasionally you come across the diagnosis, and it's not something that one suspects at the time of endoscopy. But it's often after the biopsy has been taken that the histology comes back saying schistosomiasis. So this was a patient, patient one was an elderly patient who stayed in the rural areas, and he presented with, I think, chronic bloody diarrhea. And these ulcers were seen at endoscopy, and biopsy showed schistosoma. This was so patient number 2 was a young patient who had essentially IBS type symptoms, so some abdominal discomfort and some vague changes in his bowel habit. And when one did the endoscopy, there was these lacy, abnormal looking blood vessels in the lining of the colon, and there was a little small area that initially looked like polyp, but a biopsy was taken, and the report came back saying schistosoma. Um, this was also another young patient with IBS type symptoms, changes in bowel habit and abdominal discomfort, and these nodular lesions that were in the left colon. I think this was the rectosigmoid region, and again, and this last patient was again a young man whose symptoms was diarrhea with blood in them. He had some aphthous-looking small ulcers in the colon, quite non-specific, and biopsy came back saying schistosomiasis as well. So it's an interesting diagnosis, which is not often suspected at colonoscopy, and often it's histology, which then suggests the diagnosis. So a lot of the times when we do lower endoscopy, obviously we are focused on the positive findings, and there's probably not much attention that is paid to a normal procedure. But sometimes it is equally important, I think, to be able to say that the procedure was normal, especially if the concern is for something that is potentially malignant. So I just wanted to highlight that in this series, more than 50% of the procedures that were performed were actually normal. And this was excluding the procedures where polyps were detected. So outside of the procedures where polyps were detected, more than 57% of the procedures were normal. There was no finding at all. And this is not an unusual thing, but it's obviously something that may be of interest in terms of discussions around resource utilization. So a lot of the times when patients come for lower endoscopy with symptoms, the question is, do they have cancer or do they not? And I suppose that's why, or that's how a normal endoscopy in these patients is still a welcome result, because then it is reassuring for the patient as well as the doctor that there is no cancer. So I'm going to speak a little bit about the colorectal cancer patients and describe them in some little detail. This was an endoscopy for a young patient, a young male patient who was 38, whose presenting problem was abdominal pain. He did not report much else, no change in bowel habit, just abdominal pain. And it was the sort of patient that you start the procedure and you are thinking to yourself, well, this is just a routine exclusion procedure. But unfortunately, he had this lesion in his cecum, which was cancer. This was a colonoscopy for a 63-year-old Caucasian male who had perianal symptoms, a little bit of pain in the perianal or rectal region, as well as some blood at stool. And he had this lesion, which could be seen on retroflexion in the rectum. This was a young female patient whose history included some abdominal pain and some diarrhea with blood. The details were a bit vague in terms of the duration. And again, it was one of those scenarios where one is doing the procedure and you think it's just a routine exclusion procedure, but they happened, unfortunately, to have this lesion in the left colon. And then this was also a middle-aged female patient who had I think they had blood in the stool as well as some change in the bowel habit, and they had this lesion which could be seen as well as palpable in the rectum. So I would say a little bit about the demographics of the patients who were diagnosed with colorectal cancer. And there were slightly more males than females, and that fits in with the known epidemiology of the disease. Of the Black patients who had procedures, so 26 out of the 463 Black patients had cancer, and then 3 out of the 22 white or Caucasian patients had cancer. And if you are interested in doing the proportions there, then you would come up with a slightly higher proportion of cancer in the white or Caucasian patients compared to the Black patients. The median age of the patients with cancer was 63 years. 50% of the patients were between the ages of 56 and 75. The youngest patient, which is one of the pictures I showed earlier, was 35 years old, and the oldest was 88 years old. And that table just shows the how the cancers were grouped according to the various age categories. So there were 2 cancers in patients less than 40 years of age, and those were the 2 that I actually showed in the previous slide. And then there were 2 cancers between 40 and 50 years of age, 6 between 51 and 60. The majority, or the greatest number, was between 61 and 70 years of age. And then the numbers go down a little bit with more advancing age. So in terms of where these cancers were, so the rectum had the highest number, which was 13 out of the 29. And what you realize is that the next highest number was, in fact, in the ascending colon or the cecum, where 9 cancers were diagnosed. And then there were fewer cancers in the other regions of the colon. So the rectum counted on its own for 45 or almost 50% of the cancer cases. And obviously, if one is thinking about screening or prevention or whatever other intervention, then that's something that may be of importance. And then if you the rectum together with the left colon, that is the sigmoid, and the descending gave a total of 18 patients, which was almost 2/3 of the cases. And then the right colon, which was the cecum, and the ascending, as we said, it was 9, it was 31%. So roughly you had about 1/3 of the cases being right colon cancers, and 2/3 being left colon cancers, and that's kind of similar to what is already known about the distribution of colon cancers. And then about the histology of the cancers. So most of them were reported as moderately differentiated adenocarcinoma. So that was 16 out of the total of 29 cases. So that was just over 50% were moderately differentiated adenocarcinomas. And then you had smaller numbers for the rest of the histologies that were reported, which included well-differentiated signet ring cell. And then you had this category of histologies that were reported as high-grade dysplasia. And these were patients that at endoscopy, you actually diagnosed frank tumor, but the histology would come back as high-grade dysplasia, and likely it was probably just a sampling issue where, as the tumor is arising out of adenoma, one samples the area of adenoma. I did not put down the data regarding the differences between the right and the left colon cancers in terms of differentiation, but I did look at it. and there was actually no difference in terms of how well differentiated or undifferentiated cancers were if you compared the right and the left colon. So there was no difference there. So moving on to the other aspect of interest, which is polyps. And this was a colonoscopy on a 55-year-old female patient who came in for the usual things. It wasn't a polyp screening procedure. She had rectal bleeding, I think, and probably ended up with a diagnosis of hemorrhoids, but incidentally was this polyp on a long stalk. And fortunately, because of its long stalk, it wasn't difficult to snare off. But trying to thread the snare over the whole polyp was a little bit of a challenge. And this polyp histology came back as tubulovillous adenoma with, I think it was high-grade dysplasia. So there were in total 186 polyps that were identified in 110 patients. The majority of the polyps were actually small. 95% of polyps were less than 10 millimeters, and only 5% were considered to be 10 millimeters or greater. And in the same way, 90% of polyps were sessile, and only 10% were stalked. This table shows the number of polyps and the frequency. So the majority, so most patients, about 61% of patients only had one polyp that was identified, and 20% of patients had two polyps, and 11% of patients had three polyps. So obviously the frequency goes down as the number of polyps goes up. So overall, 90% of patients had three or less polyps that were identified. So where were these polyps? They were quite distributed throughout the colon. You did have the majority of polyps being in the rectum. You had the second highest number of polyps in the ascending and the cecum, and one might postulate that this pattern seems to mirror the distribution of the colon cancers as well, where the majority were in the rectum, and the second highest number of cancers were in the ascending and the cecum. And then you also had quite a lot of a number of polyps that were in the other segments of the colon. If you categorized the polyps based on proximal location to the splenic flexure and distal location to the splenic flexure, you actually found that there was an equal number of polyps proximal to the splenic flexure as well as distal to the splenic flexure. So a bit about the polyp histology. So the commonest categories were hyperplastic and adenomas. So hyperplastic polyps were accounted for or were reported in 45 polyps, which was 34%. Maybe just to highlight that polyp histology was available in 132 polyp samples, so in about 70% of the polyps was the histology available. So in these 132 polyps, that was the baseline. So 45 of these 132 were hyperplastic, and they accounted for about 34%. And then you had adenomas. So these were tubular adenomas with low-grade dysplasia, which accounted for slightly over 50% of all the polyps. If you combined, so these were tubular adenomas, low-grade dysplasia. You had a few tubulovillous lesions with low-grade as well as high-grade dysplasia. But these were all adenomas. And at the end of the day, adenomas accounted for I think roughly about 54% of the total polyps. And then there were a few polyps that were neuroendocrine tumors. Um, Interestingly, serrated polyps were very few, and I am not sure whether some serrated polyps are actually misclassified, possibly as either hyperplastic polyps or something else. But there were actually very few serrated polyps. And then you had a few of the rest of the other histologies. So this is just a categorization of the further categorization of the polyps. And again, classifying them as either right or left-sided, and the definition here being right-sided are proximal to the splenic flexure and left-sided distal to the splenic flexure. So in this case, if you looked at the adenomas, so 41 were in the right colon and 31 were in the left colon. So slightly more in the right colon, but I don't know if this is any, it might not actually be of statistical significance. And then for the hyperplastic ones, there was a greater number in the left colon, which is what is normally expected or described. So that was just a categorization of the adenomas based on the region of the colon. So there was one episode of procedure-related colonic perforation in the series that I've just reported. Okay, so that's the a series that I was reporting, and this is the summary of it. So in 495 private clinic open access lower GI endoscopies involving predominantly Black patients, the adequacy of bowel preparation was 96%, and cecal intubation rate was also very good at 93%. There was a polyp detection rate of 22%, and the majority, as I have highlighted, were small sessile polyps, which were mostly either tubular adenomas or adenomas and hyperplastic polyps. IBD was detected in this series at a rate of 2.6%, or between 2 and 3 per 100 procedures. And cancer was also diagnosed at a rate of 5.8%, or between 5 and 6 cancers per 100 procedures. And 14% of the cancers occurred in individuals that were younger than 50 years of age. And as I indicated earlier, approximately 2/3 of cancers were in the left colon, and a third were in the right colon. And then most colon cancers had moderately differentiated adenocarcinoma as histology. So I'm going to stop sharing, and I'll hand back the time to Vikash.
Yeah, thanks, Tendai. Firstly, I must commend you. I think it's really amazing that you're keeping your data and keeping track of your stats. And that's excellent. I think too few of us are doing that. And that's really very commendable. And thank you for sharing the data for us. I think it's amazing. What I wanted to ask, Tendai, I mean, you've put up your polyp detection rate and you have showed us adenomas, but do you have your actual adenoma detection rate? Sorry, you muted?
Yeah, thanks. So that metric, I did not calculate it. The data is there, and it's something I can certainly look at. But I did not calculate the adenoma detection rate. I just put up the polyp detection rate. Yeah.
So that's very interesting to me. And anyone that has any questions or any comments, please feel free to add. But it's very interesting to me because, I mean, we've always had this long-standing belief that Black patients have less adenomas and less polyps. And it's been postulated in multiple series and multiple studies that have been pulled out. But the problem is we've never had the data to prove that. And the question was always, I mean, we still do see cancers, and the question has always been, do we follow a non-polyposis pathway with microsatellite instability, etc., in black patients? So we see a lot of young cancers, but not as many polyps. And then the other question is that going to change? Because I feel that we're starting to see more adenomas, and that's going to change with us adopting a more Western-based lifestyle. And this has always been an issue because we're following KPIs from Western literature, and even the African American population, which is where we would get our information from for black patients, is also not based on a sub or Southern Africa population. The genetics there are more probably East and West Africa. And so we're extrapolating KPIs from the international world, which just might not be relevant to us. There was an interesting paper or study presentation at SAGES by Dr. Pampalava, and she's doing quite a bit of work with KZN. She's doing work with WITS. She's doing work with UCT. And it's interesting that she presented a study where they did colonoscopy in patients who were FIT positive, plus had risk factors or red flags. And in that paper, their adenoma detection rate was, if I remember correctly, between 14 and 15%. And that's very low for a FIT positive population. The other thing, I mean, your colonoscopy series is not going to be a screening series. That's patients who are probably coming for symptoms. And the adenoma detection rate of 30% that we're using from international data, that's a screening series. So in symptomatic patients, we should certainly be seeing much more than that. And this is exactly why I put that message out in the starting, because I think we need to be keeping our data and sharing this kind of data, and we need to have Africa-specific data and then come together and see. Yeah, because I mean, it's been a question about whether we should be starting screening programs in places like South Africa. And capacity is one thing, but whether it's actually going to make a difference and whether we need to is another. And we're not going to have those answers unless we put together this data and come up with our own metrics. So again, I think it's amazing that you're keeping your stats and very grateful that you shared it with us. For example, so I don't know my adenoma detection rate, and I'm talking about a state series from Charlotte. And again, this is not screening. This is going to be patients who are presenting mostly for symptoms, iron deficiency or abdominal pain or whatever it might be. But I can tell you my polyp detection rate is in the order of about 40 to 45%. Again, I haven't looked at specifically adenomas, which I do need to look at. So I do think the polyps are there. It also begs the question that, are we missing them as well? It's
Mhm.
interesting. So it's quite
Yeah.
interesting to look at your data.
Mhm.
Other thing that's striking in your data is quite a high rate of young cancers. And that's
Yeah.
been an international trend, especially in countries where screening programs have been established. What they are finding is higher rates of young cancers, younger than 40 even. And I must say, anecdotally, we're seeing quite a bit of that in Joburg as well. We are seeing a lot of young cancers. And these patients present with quite advanced malignancies quite early on in life. The question is how do we, screen for these patients? Should we be using genetic-based screening, family-based screening, targeted screening rather than what we would call general screening? So
Mhm.
that's
Mhm.
really amazing. Does anyone else want to comment or want to share some of their stats or maybe have some of their polyp detection rates or adenoma detection rates, whether it's anywhere, from anywhere really? Anyone
Yeah,
in the
I
audience would
think
like to comment?
thanks Vikash for the comments, and obviously highlighting a few important things about colon cancer and polyps. Um, and I mean, I know you mentioned obviously, adenoma detection rates are often calculated in patients who are undergoing screening colonoscopies. In our part of the region, there aren't a lot of patients that come in purely for polyp screening. And I think in this series, the percentage of patients was not a lot. It was, I think, maybe around 10% or slightly more. Um, so we're not going to see a lot of patients. I'm actually curious as to whether, polyp detection should be affected by whether a patient is coming in for a screening procedure as opposed to a diagnostic procedure, because in the majority of cases the polyps are they're asymptomatic, they're incidental, whether it's in a patient who's got symptoms or who doesn't. So I have a feeling that we can even describe a reasonable polyp or adenoma detection rate even in diagnostic colonoscopies. So that's just my thoughts regarding that. Um, and yeah, so a few patients did have colon cancer as young patients, and it's always a challenge as to how do you screen for these patients. Obviously, endoscopy is expensive and it's technically involving, and it's also potential for complications. So one wants to try and see how you can select patients as best as possible before you do endoscopy on them. But it's really a challenging thing, and particularly for these young patients, like I said, you're doing a scope for them for abdominal pain, and turns out they actually have a cancer.
Yeah.
So how to get around that, I think, is quite challenging.
Yeah. There's
Mm.
one question in the chat, but before we get to that question, if I can maybe just ask you two questions, Tendai. The first question is, do you have any fit testing available to you in Zimbabwe, in private, in public? And the second question is, of course, you're working in a private setting, and that might be different to a state-based setting, but what's your practice with regards to sedation?
Okay, so we do have FIT available. It's accessible through or via some private labs. So that is available. The uptake of FIT is probably not as good or as widespread. I think even in the patients who are going for screening procedures are more likely to prefer to have the colonoscopy as opposed to having a FIT. And that might be the case in other places as well. But FIT is available for individuals, and I think a few individuals will opt for that upfront.
Okay.
And then your other question was,
Your
sorry,
practice with
just
regards to
me about that
sedation for
again.
your endoscopy.
Sedation, yes. So we actually sedate the patients ourselves. So we are in charge of the sedation as well as the endoscopy. And we use conscious sedation, which is often a combination of midazolam and fentanyl. So for the majority of the procedures, we are in charge of sedation ourselves. It's only in a few cases where a patient either you don't get adequate sedation or you want deeper sedation, particularly for the younger patients, where you can get an anesthetist
Yeah.
to use deeper sedation. Yeah.
Do you use propofol-based sedation? Just midazolam and
So so whenever we have an anesthetist administering the sedation, they often are using propofol, but as GI doctors, we don't use propofol ourselves. Yeah.
Mm, okay. Yeah. Thank you for sharing that. Yeah. So let's just take the question in the chat, and then I'd like to ask you one more thing as well. So there's a question here. Here in Zambia, we also, so rather more a statement. Here in Zambia, we also see very few polyps in our patients who are also coming with symptoms, and I'm sure adenoma detection rate is also low. Um, there was a question, how did you manage the perforation that you had?
So yeah, the patient had to undergo surgery. Yeah.
Okay.
Yeah.
What I wanted to ask is there any sort of system, especially for your young cancers, where the pathologist would reflexly look for things like Lynch syndrome? So reflexly look for microsatellite instability, look for PMLA, the mutations MLH1, MSH2, PMS. Is there any reflex system where they would screen high risk individuals for a genetic-based syndrome, particularly Lynch and non-polyposis?
Yeah. Unfortunately, no. It's not something that one would get as a reflex sort of testing. and I think you'd have to. I think there's probably at least one lab where that could be done, but it's not something that can be done locally. I think they would have to get in touch with some of their sister labs outside of the country to get that done. So yes, it would be actually quite an arrangement that one would need to put in place to get that done.
Yeah.
I imagine the cost as well is also an issue. So probably not done routinely or as a reflex thing, but in specific cases.
Yeah, so I think there's value in
Yeah.
that. That is being done in South Africa, especially in, like we were saying, young cancers and patients who have identified risk. And reflexing testing these patients may give us a better clue as to whether we are seeing non-polyposis cancer in our African patients. Also, then identifying pockets of patients who are at risk and then extending targeted screening to those pockets of patients. That is something that has been mentioned before as well, and I think is something worthwhile. For example, the pathologist that I utilize in my private practice would routinely do that as a reflex in high risk patients or young patients or whatever it is. And that might shed some more light as to whether we actually are dealing with a non-polyposis pathway to cancer in Black patients, or whether, they're following the traditional adenoma carcinoma sequence and its lifestyle and factors that are contributing to colon cancer and the development of colorectal cancer. So, yeah, if you do have the capacity to do that, that I think is probably worthwhile. Again, not in
Mhm.
every patient, in those elderly
Sure.
patients who are, clearly identified, then and then you can extend screening to within that family or that community, whatever it might be, your fit-based test or whatever it might be. But
Sure.
that's one approach. Because the issue is, I mean, we really aren't ready for screening. In order to run screening, you have to have endoscopists to do the scopes when you have positive screens. You have to have surgeons to do the surgery. You have to have oncologists. You have to have ICU. You have to have all of those ancillary services available. And if you don't have the endpoint available, then it's pointless starting, and then you overload the rest of the system. So we're
Yeah.
certainly a long way away from that. Any other comments from the chat, from the audience? I don't see any others. Again, thank you, Tendai. I think that was really amazing. It's awesome that you're keeping your stats and that you shared that with us. And I really must commend you and congratulate you on that. And a plea to anyone from anywhere in sub-Saharan Africa, if you'd like to share some of your data with us, your practices, interesting studies that you might be doing, or just give us some insight into the state of endoscopy in your country, we welcome that. Just reach out to me and we can see if we can get a slot for you on one of these sessions and share that. I think that's very valuable, instead of hearing the same speakers and we talk about things that are probably not relevant to our practice from Western-based practices and interventional endoscopy and that, but rather something more specific and something more practical that will impact our practices. So with that, I think we can close the meeting. Again, thank you to Tendai for sharing his experience with us. Thanks to Echo, University of New Mexico, and the Echo India team. As always, the recordings of these meetings are available on the Gastro Foundation website. Thanks to the Gastro Foundation, Prof. Cassanides and Prof. Thompson, who unfortunately couldn't join. And thank you to our sponsors. Next week's meeting is IBD, and hopefully some of you will be able to join on next week's meeting as well. Thanks again. Thank you all.